today, titled as endoscopic septoplasty versus non-endoscopic septoplasty. As it is well known for the all rhinologists particularly, and for ENT surgeons generally, that the septoplasty is considered as one of the most common procedures which are conducted in this specialty. Either it is conducted for main aim as a relief of the nasal obstruction, or conducted as a concomitant procedure, as I mentioned yesterday, for the other procedures as the first procedure. The obstruction which is indicated, the nasal obstruction which is indicated for the septoplasty procedure, either to relieve the nasal obstruction directly or to improve the ventilation to the paranasal sinus, stachy tube, and middle ear cleft. In addition, as it is the main aim of the most of the surgeons who are conducting this procedure, is the complete correction. The surgeon is acting for the complete correction of the defeated nasal septum as much as possible, despite of the preservation of the nasal septal skeleton to reduce the risk of the septal perforation, also despite of the preservation of the contour of the nasal septum to reduce the risk of the post-operative aesthetic changes. Because this procedure is a very common procedure which is conducted in the ENT specialty, and it can be conducted by the juniors as well as the seniors too. That's why there are a lot of studies and the clinical trials.
Sorry, Dr. Khaled, Mohamed, sorry to interrupt you. Do you have slides?
Yes.
So please share your slides. We cannot see your slides. Okay.
Is it clear for you now?
Yeah, it is clear.
As I mentioned, as the septoplasty is a common surgical procedure which is conducted in ENT specialty, the slides are clear for you now?
Yeah, it is clear, Dr. Khaled. It is visible.
As I mentioned, the septoplasty as a surgical procedure, which is commonly conducted in ENT surgery. That's why there are a lot of clinical trials and studies which try to improve the many issues which are coming along to this procedure. One of these issues is the dilemma of the improvement of the technique itself, just to achieve the most optimum outcomes. As the last year's advancement in the endoscopic surgery, there are a lot of trials to improve the septoplasty procedure via the using of this technique, which is the endoscopic technique. That's why this study was conducted actually as a comparative study to compare the two techniques, the conventional non-endoscopic technique as well as the endoscopic technique. And in fact, this comparative study was done in relation to the achievement of the most maximum correction of the deviation without the significant residual deviation, in addition to the incidence of the most post-operative worse complications of this procedure, which is the septoplasty, which is the septal perforation, as well as the post-operative aesthetic changes. In addition, we tried to compare the difficulties regarding the performance of these procedures, whether the endoscopic and the septoplasty is more difficult or the conventional create more difficulty as compared to the other. The study conducted from 1998 to 2022 and including 2,304 operated cases, the 672 were interfered with the endoscopic technique, while the others interfered with the conventional technique. The patients who are included in this study was of wide spectrum of age groups, and also they are presented with different types of the deviation, namely anterior caudal dislocation, C-shaped deviation, S-shaped deviated nasal septum, as well as the nasal spur, with different predisposing factors, mainly the post-traumatic deviation as well as the developmental deviation, and they are exposed for the follow-up period from 6 to 12 months. As we can illustrate from this bar chart that the endoscopic septoplasty creates more chance for the postoperative correction of the deviation as compared to the other conventional technique. And this simply can be interpreted and explained by the fact that in the endoscopic surgery or endoscopic septoplasty technique, the field or the surgical area or the field is completely visualized. The entire nasal septum can be seen completely, including the deeper part of the nasal septum, and this will give a chance for the surgeon for the proper correction and proper reconstruction as compared to the other more or less blind technique. The other bar chart, as we can illustrate, the incidence of the most worse complication of the septoplasty, as it is well known for the all people who are working in this field, that is the septal perforation, which is difficult to be managed. If it is occurred, difficult to be managed. As we can see from this bar chart that the endoscopic septoplasty creates significantly a less incidence for the septal perforation as compared to the other conventional technique. And this can be explained by the same explanation that in the endoscopic surgery, there is a chance for the surgeon to elucidate the deviation exactly and correct it accordingly. In the same time, you can evaluate whether there is any evidences of traumas, iatrogenic traumas to the septum or to the flap, which can be managed accordingly, and this will reduce the risk of this outcome. Regarding the postoperative aesthetic changes, as we can illustrate from this chart, that the studied aesthetic changes mainly are the supratip deviation, supratip depression deformity, the saddle-shaped deformity, and the crooked deformity. As we can illustrate that the endoscopic septoplasty creates a lesser risk for these aesthetic postoperative changes as compared to the other conventional technique. This can be explained by the same explanation that in the endoscopic septoplasty, the technique itself is more preservative, more reconstructive, more functional as compared to the other more blind conventional technique. The difficulty is assessed the difficulty of the procedure itself is assessed indirectly by the assessment of the intraoperative time consumption. As I mentioned yesterday, in my talk yesterday, that the difficulties can be overcome by the proper visualization in the sinus surgery. The same here, the difficulty can be overcome by the proper visualization of the entire skeleton of the septum. And this can be achieved only by the endoscopic technique. Once the tissue or the structures are visualized probably, so the technique will be more easier, will be more safer, and therefore the difficulties can be resolved. As we can see here, the time consumption in the conventional technique is significantly higher as compared to the endoscopic technique, which will provide the proper visualization of the field. Thus, the technique can be performed in more easier manner. So our conclusion is that the endoscopic septoplasty is the procedure which done under a very close vision, and the entire septum, including the deeper part, is completely visualized. Thus, the correction can be done in more easier and more safer performance. In addition, the post-operative handicapping most worst complications of this technique or of this surgery, which is the septal perforation, as well as the outer exterior nasal aesthetic changes, as shown, are of less incidence significantly among the endoscopic septoplasty as compared to the other technique. I like to give some recommendations before I leaving, that although in our study, the interpreted outcomes shown that the endoscopic septoplasty is more effective and safer procedure as compared to the other technique. But still, as it is well known for all people who are working in this field, that this is not sufficient. This is considered as one factor, which is the technical factor. There are another factors which might affect these outcomes, as the septal perforation and the postoperative aesthetic changes, and can be considered as important factors as compared to the technical factor, as the patient's demography, the patient's health status, and also we have to concentrate on the local factors, as the type of the deviation, the severity of the deviation, the times of the performance of the surgery before, and whether the cause of the deviation is traumatic or developmental. In addition, the number of the cases who are studied and interfered endoscopically in our presenting study was incompatible with the number of the cases of the other group. And this, in fact, will decrease significantly the strength of the results from the conclusion point of view. And therefore, I recommend for further studies with more compatible number to make the comparison as more conclusive, as more informative, as more confirmed as much as possible. Thank you a lot for your attention, and whether there is any questions.